So our speaker today, Dr. Michelle Lofwall, is a professor of behavioral science and psychiatry at the University of Kentucky College of Medicine in the Center on Drug and Alcohol Research. She is the Bell Alcohol and Addictions Chair and Medical Director of the First Bridge Clinic, which provides comprehensive outpatient opioid use disorder treatment to patients discharging from emergency rooms and inpatient medical surgical services. Her research has been funded by NIH, and industry is focused on improving the treatment of persons with substance use disorders. She was an expert panel member on SAMHSA's treatment improvement protocol, tip 63, for medication treatment of opioid use disorder, a past board member of the American Society of Addiction Medicine, and president of the Kentucky chapter of ASAM, an invited speaker to the National Academy of Medicine, and recipient of several medical student teaching and mentorships awards. So please, everyone, welcome Dr. Michelle Lofwall.
Hi, everyone. Thank you for that introduction. We need to make a shorter one, John, for the future.
All right.
So I'm really excited to have all of you here, and I can see names that I recognize too. So that's really lovely. So, we just want to better understand addiction. And I find that the more I talk about it, the more I understand it. And the more I talk about it with other people, the more insights I get, always getting insights from my patients, but then kind of being forced to talk about it with other people who don't have the experience of addiction or maybe have some misinformation about it is always keeps me on my toes. And I know many of you are peer support specialists and always have to be on your toes too, to explain this, and care navigators also, as well as, you may have family and friends. So just really happy to have you all here. Lots of times, substance use disorder is often looked at as a moral failing and not as a medically treatable chronic kind of illness with lots of different psychosocial factors that impact it. And so we want to change that. That's an example of misinformation. So, we want to be able to think about substance use along a spectrum, and addiction being the most, kind of severe form of substance use. We want to be able to describe the brain changes that occur in response to substance use, as we see in substance use disorders as they go from mild to moderate to severe, and use accurate terminology that's not stigmatizing. So we want to leave here with having a better understanding of the clinical terminology to describe some of the basics around the epidemiology, which is really like about prevalence, incidence, and the public health impact of substance use disorders, list some common comorbidities, because lots of times people have other illnesses that go alongside. And how, using a chronic treatment principle can be really helpful and be applied to addiction treatment in order to really help care for the individual. And in doing so, you can help care for communities better and families and public health. So we'll start with an overview about some of the myths and misconceptions and some of the critical conversations that we think we want to have. So the first is stigma. I think it's always there, and I think that it just is, my eyes kind of become more open and see it more often. Stigma is a set of negative and often unfair beliefs about a group of people that have something. And sometimes it's a set of beliefs that a whole society shares. Recovery is the act or process of becoming healthy after an illness or injury. That's like the dictionary definition. SAMHSA's definition that we are more commonly employing in the Healing Communities study is a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. Recovery is built upon access to evidence-based clinical treatments and recovery support services for all populations. And so recovery and treatment are not the same thing, but within that definition of recovery, it's really important to note that it includes access to evidence-based clinical treatment and recovery support services. And it's because of the belief there is that, you know, there's illnesses, and that if you don't provide treatment for the illness, how is the person ever going to improve their health and live a self-directed life if they can't access, you know, treatments that decrease mortality and morbidity. So just noting that recovery and treatment are not the same thing, but that doesn't mean that they can't go together. Actually, I think the most beautiful outcomes come when an individual with an illness actually understands what their treatment options are and can make the decision for themselves if they want treatment to be part of their recovery. And to be basing that on correct information, so that maybe they're making informed choices. They have a sense of agency over their life, and that, you know, so they do not have to be separate. They very much can go together and really kind of have beautiful outcomes when going together. So what are recovery support services? So recovery support services fall into 4 major dimensions of a life in recovery. The first dimension is health. And so there, you know, we're thinking about services that help overcome or help an individual manage one's disease or symptoms. So it might be that, you know, they don't have the information to know what their choices are that support physical and emotional well-being. They don't know about what's available in their community in terms of resources for mental health treatment. They don't know what methadone does, what buprenorphine does, what naltrexone does. The second thing, home, you know, we want people to have a stable and safe place to live. It's really hard to find a sense of purpose and meaning and all that without having this basic kind of, I think, foundational thing that we would want everyone to have, a safe place to live that's stable. Purpose. So, you know, all human beings, we all do best when we have a sense of purpose in life. And this is, you know, about our day-to-day life, you know, meaningful daily activities such as having a job, or if you are disabled, having other activities that give you a sense of meaning. For some, it's, you know, their primary role is as a student. It could be volunteering, family caretaking, creative endeavors, a sense of, you know, that they're an individual, having some income and resources to take part in society. So, and then the last is community. So, you know, people are meant to be with other people. And so having healthy relationships and social networks that provide support, friendship, love, and hope. So our definition of substance use disorder comes from the Diagnostic and Statistical Manual. We're in our 5th version. To make a diagnosis of a current substance use disorder, you have to have more than 2 items in a 12-month period. These include a failure to fulfill responsibilities in life. So think about what that person's role is. If it's that they're, you know, a student in school, you'd be asking questions about, you know, are they getting their grade, are they getting their work done on time, their homework on time? How are their grades? If they're a family caretaker, how are they doing in that role, taking care of children, or maybe it's elderly parents or someone else at home. If they're, you know, an employee and have a job that they go to, are they consistently going to work? Are they late to work? All of those kind of things. So figuring out what someone's major responsibilities are in life, and then kind of seeing how they do there is what we look at when we decide if someone is meeting this criterion due to their substance use. Are they using that substance in a physically hazardous situation? So are they using the substance and then going and driving, or using operating heavy machinery? Do they have cravings? So this item replaced legal problems that was in the old DSM-4. So by craving, we mean like, you know, some people will just come out and say, I'm craving, but other people will say things like, I just have this urge, or I have this thought, or I have this like just sense that I have to use. Like, I don't even want to have this thought. I don't want to use, but like, it just keeps coming back into my head, even though like I don't want to do it. So it's all of those things. It's kind of that what we call here craving. As a psychiatrist, I often think about it as an obsessional thought too. So sometimes it's unwanted, it's undesired, but it's intrusive, and it just keeps coming back, and it's incredibly frustrating for people. Having social or interpersonal problems due to the drug use, think that one kind of stands alone and it's easy to understand. When people are using the substance for in larger amounts or for a longer period of time than they ever intended. So it's pretty rare that you meet someone who's currently addicted and they tell you, yeah, that's what I intended. When I first had my first use, I actually fully intended to be using every day, multiple times a day, and to be giving up all these other things. They usually will say, that they never intended to be where they are right now when they first started using, that took some time, and that gradually they found they needed more of the substance to achieve the same effects, which is tolerance, or that they find that when they stopped using it or tried to cut back, that they started to feel sick. So, which goes into items 10 and 11, that's your tolerance and withdrawal. But then, that saying like that they can't cut down, or they've tried to cut down and they can't stay with that. They always kind of go back and start using. That's that 6th criteria, where they're spending more time to get the substance, use it, and recover from its effects. So like where they're getting up and they're planning their day, how much supply do they have, when, and then thinking about where are they going to get the next amount for the next day or the next days, and when are they going to use. Like there's just so much mental life spent surrounding the substance use, and time, where they're giving up then other important parts of their life. Maybe there were hobbies or other passions that they had, other people that don't use that they no longer are spending time with. And when they continue to use despite having problems, legal problems, relationship problems, employment problems, that there's just continued use despite that. So what you see here are the criteria. They then, you check the mark. If they have that criteria, you add them up. If there's 2 or 3 criteria, it becomes a mild severity use disorder. If there's 4 to 5, it's moderate. And if it's severe, there's 6 or more. So that's the definition. And we ask these questions about each class of substance. So, if someone's using cocaine, you would ask about all these things. Are you failing to fulfill responsibilities due to the cocaine use in physically hazardous situations? That's use of cocaine. So all of these questions would be asked for each class of substance. So this is a slide showing you the prevalence of people with opiate use disorder in the general population of community dwelling persons aged 12 years and older. This is an annual survey conducted by SAMHSA. It's called I'm forgetting the name of it, but it has a lot of limitations. It's community dwelling, so it's not really doing a great job at getting hidden populations. So it's considered a underestimate. Some people believe that it's closer to 2 times the number that you're seeing here. We're always several years behind with this. I would say it's upticked a little bit with our most recent year, about 2.5, 2.6 million people in the United States now with an opioid use disorder. In the past year, you can still see that the most common substance use disorder in the United States is alcohol. I would say more than that is a tobacco use disorder, a nicotine use disorder, but they don't measure that. And then it's marijuana, and then you're going to have the opioids, including both the prescription pain relievers, heroin, and now most commonly the illicitly manufactured fentanyl. And then that's going to be followed by your stimulants, the cocaine and methamphetamine. So what's unfortunate, just to go back here with this last bullet point, is that with opiate use disorder, we do have some FDA approved medications that we'll talk about in a minute, but only 20% of people that have an opioid use disorder actually receive specialty addiction treatment. And then among those, only a little bit over a third receive an FDA approved medical treatment, which is just, it's not enough people that we're getting to. And that's why we have the Healing Community Study, right? So why we're all here is to try to bridge this gap. So you could say, like how have we gotten here into this space? And so sometimes it's helpful to go back and look at our history. And so this is just a little bit about the history of recovery and some early treatment. And so, there really was no evidence-based treatment in the early 1900s. AA started in 1935, was really looking at things as one day at a time, took a chronic view. Members relapsed, but they took them back without judgment. It's common for within AA that the members called themselves addicts. This wasn't meant to be harmful to them. It was meant as more of a kind of ownership that they have this problem, and a sense then that they were then able to take responsibility for it. I think the downside of that term is that sometimes now we see that as for some people that ends up being stigmatizing, where they define themselves entirely by the substance use disorder, and that can hold some people back. So now we use the language of a use disorder, and we try to have person first language. So we would say a person with this substance use disorder, a person with substance use. But such important contributions with AA, they saw that the adversary was death. So true. They accepted that people needed to go to the hospital for acute treatment, and that the addiction really was causing a loss of the person's control over their life. So there are implications that I think are very true still today, is that recovery is a lifelong process, that there's no guarantee of abstinence. And they really emphasize the importance of hope and fellowship, and this idea that there's an important sense of community more than oneself, which gets at that whole purpose. The acute models of treatment in the early 1900s and even some of the mid 1900s were very harmful. Prefrontal lobotomies were done. And then in the 1930s, the Public Health Service wanted to have a way to send people who were criminally justice involved and allow them to bypass going to formal jail and prison. And they said, let's, send people away for a cure. And you know what? Lexington is absolutely gorgeous. So we're going to send them for the Lexington cure. And that's how the Lexington Narcotics Farm really started out. And this was an attempt to do research and to try and help people. And this is where some of the first data were received, showing that methadone was an effective treatment for opiate use disorder. And they also tried to teach people vocations while there. They later changed the name because there was a joke being like the narcotics farm. Okay, where do you grow the narcotics? And you can see a picture here. It's still off Newtown Pike. But what they found was that even after people were here, and lots of times it was, over a year, that over 85% of people relapsed despite, getting great counseling and all this kind of training and how to have a successful job and that when they went back home. And so what we found over and over again with many, many studies is that relapse is the most common outcome after treatment ends. And we'd thought for a while, or some people thought for a while, that maybe it was going to be different with prescription opioids, because those were people who were getting prescribed them. And those studies have been completed now, and they show that it doesn't matter. An opioid is an opioid is an opioid. It's still acting at the same receptor if it's pharmaceutical or non-pharmaceutical. So it's a deadly disorder. We all know this. Some early work that actually, showed us this before the real epidemic got going in the 90s, with people dying 20 years earlier compared to those without a substance use disorder. And the major risk factors for opiate use disorder, one of them is loss of tolerance, which is why detox can be so dangerous for people because they're losing their tolerance. And then when they go back and they have a slip, that they've lost that tolerance. And so that can be a deadly return to use. And so where does, detox happen? And now we like to also call this like socially managed withdrawal or medically managed withdrawal. Frequently it's happening in our criminal justice system because treatment is not available when people enter upon demand. So people are kind of forced to go through opiate withdrawal. And so we do see very, very high rates of relapse and death after people are leaving jails or prisons. So this is just something that's really, really critical to know. If you have a client that is saying, I need to be detoxed, I need to be detoxed, just to say like make sure they're educated and that they understand their treatment options, because that loss of tolerance can be quite deadly. And it can be confusing to people too, right? Because you're telling them that their desire to not use anymore is potentially a risk factor for them dying. So like it kind of makes sense a little bit, right? That some of your community might be confused about this. So it really does require a lot of education. And this is why, we have these 3 FDA approved medications that, as long as they're willing to take one of them, then that's going to be really, really helpful to keeping them alive. So why were recovery support services and early treatments not curing addiction? And I think it was because there was a failure to understand what substance use disorders or addiction was. And the very interesting thing about opiate use disorder, specifically when you lose that physical tolerance, how you're at really elevated risk for death. In combination with the fact that we had no effective medication treatments until the 1960s. But now we have decades of research showing that this is a brain disease. There truly are brain changes. It's not an allergy. It's not a character flaw or spiritual deficit. And there are really, really effective treatments. They're not perfect. There is no treatment that is perfect, but the outcomes that we can get from 2 of the 3 treatments where you can reduce death by more than 50% is just, we are so lucky to have that. That is amazing. So again, just reminding you of the criteria, and I don't like having to memorize things. It's always very hard, takes up too much brain space. So I think what I have learned from others and have passed on to like students and fellows and residents and my own kids and family and friends is, if you can just remember the 3 C's. So craving, compulsive use, like you just have to do it, you keep doing it even though you don't really even want to do it, and consequences. So like you're having consequences and you still can't stop, you're in trouble. You've got a substance use disorder that is really, really active, and that it would be in your best interest to really see someone who's expert and get an individual evaluation and get some individualized help. So the 3 C's, that would be my recommendation. So you don't have to memorize all this. So, lots of people will say, well, it's a behavior, just don't do it, right? Nancy Reagan's just say no. So, and, behavior's always been like one of my favorite things. It's why I actually chose to really specialize in addiction, because behavior is so complicated and interesting and malleable. So, which means it can change, but not all that easily. So I wanted to just take some time to try to explain this a little bit, because this is also, I think sometimes how the community gets confused, like they focus on that choice thing and they're like, well, if there's a choice, they should be able to stop. And behavior is in the seat of the brain, and the brain really controls everything, right? Like it controls your autonomic function, it controls your nervous system. It is tons of stuff that we've learned through conditioning, and just the fact that I can talk to you and right now, and I don't have to think about every word that's coming, that's because my brain has learned this, right? Like there's so many unconscious things that my brain is doing right now. So I can be here and be talking about this. It's not that I've had to memorize what it is that I'm saying. And so behavior, I think, is, if I try to simplify it with regards to someone who has, the 3 C's, there is an element of choice always. There's physiological drive, that really is different when someone has had repeated use, where it becomes something that the person is having the 3 C's with. And then there's conditioned learning. And so it's all really complicated, but what I'm saying is that when someone, and what the research has shown is that when someone has developed a moderate to severe substance use disorder, has craving, compulsive use, and continued use with consequences, and can't stop, their brain has changed in such a way that there is now a physiological drive focused on that substance. Just like we have an innate drive to have sex, to eat, and to sleep. Where if we don't sleep and if we don't eat, we are going to become sleep deprived. We're going to get incredibly hungry, and our brain is going to automatically, without us asking it to, be focusing our attention on getting to sleep and on finding food. And we might make choices to fall asleep, even if we don't want to, in situations that are harmful. Like, and as doctors and stuff, you know, the whole work hour thing had to change because there was a time, you know, over a decade ago where there were no work hour limits, and doctors would fall asleep standing up and then hurt themselves or hurt a patient. There were stories of, you know, people falling asleep while driving, right? And it's not that that's what they wanted to do. It's just that they were so sleep deprived, and sleep is there is a physiological drive. It's meant there to preserve the person staying alive. And then you know, your appetite and eating, you need food to survive, right? And so if you go without, so what happens with the substance use disorder is that you get this innate drive to use the substance. The brain gets confused and thinks that it needs this now to survive. Okay, so the medications, specifically the ones that stimulate the opiate receptor in some way, dampen down that physiological drive. And that can make all the difference to someone to allow them to make different choices in their life. But you still have this thing called conditioned learning, which is, how were you raised? Who have you been using with? What are the behavioral patterns of reinforcement that you have learned over time? And so it's like, you know, how do you respond to different things? It's like all the really like kind of rich things that make us human and make us all like really different from one another. And they're patterns that get repeated over and over and over again. And so people have learned a whole bunch of different things around their substance use. And so one thing we know is that punishment doesn't work. So you want to look at what, you know, as the physician, or if you're like a therapist that's working with someone that's addicted, is you are trying to learn what has your patient learned? What have they been conditioned to learn? And sometimes patients don't even know that this has happened. So it's the reason why we look at the people, places, and things at a patient at an individual level, because that tells us the conditions under which someone has been exposed and has used and what has happened as a consequence. And if those things have been repeated over and over again, we know that those are aspects of therapy, of intervention that we're going to try to intervene in. So that's going to be part of your behavioral modification, if you can affect that. One of the reasons why we want to really impact criminal justice is because frequently what's being repeated there is punishment, and punishment doesn't work, and it doesn't help. So I'll just say, right, so I hope you're kind of understanding things here, where the therapy behavioral modification is really being targeted at the conditioned learning. It has to be set up at an individual level. And then the physiological drive, that's where your medications are really trying, especially methadone and buprenorphine, are really trying to dampen down that drive to use. And that together, people can then start making different choices that are more advantageous to recovery. and remission. So remission is having no more signs and symptoms of the illness. And that's another term that we really want to be using a lot more, because it's a medical term, it's real. You do go into remission from opiate use disorder, just like you can go into remission from cancer. And I think it helps remind our communities and ourselves that this is not just simply a person's choice or a characterological flaw. This is really, really complicated. So, I said all of this, conditioned learning. And so, there are so many different ways that people get conditioned, right? There's within society, like the country that they live in, there's conditioning there because of cultural values. If the person has been immersed in a subculture where there's, the social networks that they're involved in primarily are all using illicit substances, then there's the norms that they're going to be exposed to within that subculture that have been conditioning them. There's their community, the family, the dyad, maybe if they're married or they have another significant relationship with someone else. This is very important. When we know that when people inject for the first time, it's usually not themselves injecting them. It's usually someone who's very important to them, a loved one, a significant other in some way. And there's the person themselves, and then their individual biology. And we can then go all the way down to, molecules and atoms and all of that. This is why there's basic scientists who are studying addiction. So when you say, is it my genes? Is that why I have addiction? Is it my environment? The answer is really both. It's complex. It's about 50% genetic influence, 50% environment. Environment, big factors are availability. And so there is so much more availability now, right, of illicitly manufactured fentanyl, heroin. There's so much more availability of alcohol, I would say, as well. Peer use, drug using partners, having a history of victimization. These are all kind of factors in the environment that influence the initial use, continued use, and then the development of a substance use disorder. So again, just trying to remind you the 3 C's: craving, compulsive use, consequences, continued use despite those consequences. So the essence then of a substance use disorder is that it's a brain disease expressed as a compulsive behavior. There's persistent use despite harmful consequences. This behavior develops its own drive or appetite. That's that physiological drive. That was one of the 3 components in that figure. And that the brain has really changed once it's addicted. What was conscious at first, like, okay, I need to inject this, so I need my tourniquet, I need my filter, I need my spoon, I need to go through these steps. It gets repeated so many times that you can kind of go on autopilot with it, just like you can probably ride a bike now without having to think about where to put your foot on the pedal, where to put your hands on the handlebars to balance, just like you can drive, and you can probably think about, if you're going to the grocery store, what you need to get, right? And you don't have to pay attention to the traffic in front of you. You're able to stop and monitor somehow, right? That's your brain learning things that you've repeated over time. So your brain's just doing what it thinks it's supposed to learn when you're using substances. It's like trying to make it easier for you. That's what healthy brains do. But this is not something that we wish that it would learn, but we don't have control over that. And so, all the different pathways in the brain that are getting changed, it's not just the learning of, okay, now, the steps and the use, it's also, changing motivation and reward circuits. These are also, and memory is also clearly getting altered. So this is in a, oh gosh, we don't have the reference. I think the references are at the end, but there is a Surgeon General report that was in, I think, the last 5 years that was completely focused on addiction in the United States with, really concerns that the Surgeon General had. It's like our chief medical officer of the country, about not just opiate use disorder, but about alcohol, tobacco, like all substances, that there's just more and more Americans that are becoming addicted. And there are common changes in the brain with all substances. There's changes associated with binge and intoxication, and that involves areas of the brain known as the basal ganglia. There's changes in the brain associated with withdrawal, which is, when you're feeling those physical symptoms of withdrawal, it also goes right along with having a very negative mood or affect, where a lot of anxiety, depression, just really don't feel good. And then there's an area of the brain that's associated with preoccupation and anticipation of using that substance once again, that, oh, I'm going to feel better, or this is going to fix it. And that involves our executive function, the front part of our brain. And we develop deficits in those with continued use. So we don't make really decisions that require that very human part of us that differs. It's almost like it goes, it gets turned off, like the shades are pulled on it. So like it really is hard. It really is truly much harder to put the brakes on because of the brain changes happening with repeated use over time. So this is a JAMA study that was published over 10 years ago that was just trying to destigmatize drug addiction, to show that, the fact that people are saying they want help and they go and get help, and that they then relapse or have a return to use, trying to say to all of us, this is not that different from type 2 diabetes, hypertension and asthma, which also have, lack of perfect outcomes once someone comes in for treatment. People still have asthma exacerbations. They still have episodes of high blood pressure, and they still don't have perfectly controlled blood sugars. But we don't throw out treatment because of that, or blame that, just sort of say, yeah, treatment doesn't work, let's just try something else. They just need to, control their diet and exercise more and stop smoking cigarettes for their asthma. So this was just, I think, just a really pivotal study that was really trying to destigmatize. And I think, the point that we were trying to make is that it's much more unforgiving with drug addiction, right? Especially opiate use disorder, that it's unforgiving because of all the stigma and shame that people carry with them. And also because there's so much lack of understanding, I think, in the community too. So, and of course, death with all when they try and stop. This was, like I will get this a lot, like where, I'll have patients, or my colleagues will have patients, and then, the patients don't have perfect outcomes. And then there's so much negativity that then comes from, maybe family or friends that were then involved in some way. The patient was in treatment, they get very upset with you as the provider, or they get very upset with the therapist or someone else that's part of the treatment team. And then you start, hearing things, oh, you need to be, we need more rules for this, or we need more rules for that, or, like just trying to like be so much more like controlling and impatient. And, it's just, if you think about all of the time it has taken for the person to come to this place, this idea that they are going to stop using and be in full remission for the rest of their life without any slips, especially in the context I just showed you how common non-perfection is with other chronic illnesses. It's just unrealistic. And that doesn't mean that there's still a failure of benefit. So this was a slide coming from Norway. And I think the major point is that it is really important that you understand, that you all understand that there are benefits to treatment with the 3 FDA approved medications, even if it's not perfect. That what we are aiming for is quality treatment. There is no perfect treatment. Even if you think, you have the best doctor or the best clinic or something, there is no perfect treatment. That quality treatment can benefit patients and public health despite it not being perfect. And so this was the closest study that I could find to try to illustrate this. So in Norway, they have had syringe support programs for much longer than in the United States. And so what they did was they looked at people coming to those syringe support services, and they figured out if those were people who were currently in treatment getting methadone or buprenorphine, there were 341 of those, or if they weren't in treatment. And then they looked at the rate of non-fatal overdoses, whether or not those people were committing thefts, dealing drugs, and using heroin daily or near daily. If the number's lower than 1, that means being in treatment has a much lower risk of these things than those who are not in treatment, right? And you could say, you know, and the reason I put this up is because I have heard some people say, well, if you're in treatment, you shouldn't be allowing your patient to go to a syringe support program. Well, like, why? Because you think that the treatment's not going to be still helpful to them. So I think like this just really shows that despite the fact, yes, I really wish that my patients who have opiate use disorder and who I am prescribing buprenorphine, I know most of them are now injecting drugs. That's how they, right, that was their preferred route. And it's been going on for years and years and years. And so I hope that if they do continue to use, I hope they do get very sterile needles and that they know how to access those. And so I hope too that there is a benefit to them. This study shows that there is still a huge benefit. They are half as likely to have a fatal overdose being on methadone or buprenorphine than if they weren't in treatment. And much less likely to be committing theft, dealing drugs, and using heroin daily. This is so not perfect, right? Because it still indicates they're probably still injecting drugs, but we are keeping them alive. They are committing fewer thefts, which is good for public safety. They are dealing less, and they are using much less heroin. So just, I think, keeping this thing in your head, especially as, there's lots of regulations always out there. There are benefits without perfection. So I bring you back to this triad of choice, conditioned learning, and physiological drive. So we reduce illicit and risky drug use when we use medications by different mechanisms. We suppress the withdrawal symptoms, so that suppresses the physiological drive. And the two medicines that suppress withdrawal are methadone and buprenorphine because they stimulate the receptors for opiates in the brain. They suppress craving. So methadone and buprenorphine can bring craving scores down from, about an 80 out of 100 down to about 20. Okay, so a huge reduction in craving, more than a 50% reduction in craving with those two. Naltrexone can bring it down by about 10 points is what we've seen in the studies. So I put the question mark there because I just don't think it's as robust, but some patients may tell you it does help much more than others, but you get the most reduction in craving with methadone and buprenorphine. So again, that's working at that physiological drive part. It stabilizes the dependence level. That also is working at the physiological drive portion. And it blocks illicit opioid effects. Okay, so to deter use and to decrease the risk of overdose and death. That is working at conditioned learning, and that's all three. Because if you have someone who agrees to take their medicine, and their medicine, whether it's methadone, buprenorphine, or naltrexone, all three of those are binding to that opiate receptor. And if they take that medicine and then they go and spend money or do whatever and get and use fentanyl or oxycodone or heroin, they are not going to feel that as nearly as much as what they would have felt it if they weren't on those medicines. And what that does is it makes it less rewarding. It makes it less, it changes what they're used to seeing happen. Right. So it's breaking up that learning cycle. That is what they've learned before. They've learned before that if they used, they didn't feel sick anymore, or they had some more energy, they felt better. And there's nothing happens. So that's starting to work at conditioned learning. And what we're trying to do is extinguish behaviors. And that takes an incredibly long period of time. And here's where I think that we can all develop a little bit more compassion if we don't have it already, if we haven't been addicted ourselves to a substance. Try to think of some habit that you have. So something that you kind of do a lot that you know is not healthy for you and that you would like to change, and maybe that you have tried to change and it's just been, maybe you've been successful, maybe you haven't, but just realize it probably wasn't, something that you sort of said, yeah, I'm going to stop that. And then you just very easily dropped it. I mean, if you are, then like maybe email me or something and we can talk, because I'd love to learn. I love people that can do that, can tell me how you did that. But most of us can't do that. And most of us have some behavior that we know isn't healthy for us, whether or not it's, late night eating of, heavily processed foods like potato chips or something that maybe is, something that we wish we could get rid of. It might be something else, but I think that helps. Like if you then like really think about how hard that was for you, or maybe how you ended up finding yourself eating the potato chips or something else, and you're like, oh, I didn't mean to do that. I just went into the pantry and got those chips. Ooh, right? You really kind of have to, maybe the way you were successful was you got rid of all the potato chips in your pantry. You couldn't have them available to you. So you were trying to change your environment. You're trying to, change your habits, what you've learned, and trying to maybe do something else in the evening instead. So I think it's important to try to find something so that you realize how hard it is for patients with addiction to really try to go into remission and have a meaningful recovery. It is really, really hard. This is so important because misconceptions bring stigma. So I've heard, some people kind of say, well, if you say it's a brain disease, it means the individual has no responsibility. And I hope that you realize that's not what I'm saying, that you saw choice always in that triad. What we're trying to do is make it a little bit easier for people to make healthier choices. Otherwise, it's like they have to be fully conscious all the time of every single thing that they're doing. And that's just really, really hard to do because it's exhausting to have to do that. Just like think about how much of your day you actually do on autopilot, and that we rely on our unconscious brain to get us through the day. So if your unconscious brain has learned these unhealthy things that are constantly driving towards substance use, it is incredibly hard for an individual to then remain fully conscious of all those decisions to avoid that. A marker of a spiritual flaw, absolutely not. Spirituality, I think, can be certainly part of someone's recovery. And frequently you'll hear people say, we want to think of treatment plans that are biopsychosocial, spiritual, and even nutritional. To say that it doesn't affect me or it could never happen to me or anyone I love, I think there's just no way that you can know that. That would be another misconception. And with the overdose epidemic as it is, I think it's increasingly common that people do know someone somewhere who it's just been absolutely devastating to lose someone. That I should be able to stop on my own because it's a behavior. Yeah, behaviors are really complicated, right? And so hopefully now you understand just how much your brain changes with behavior, and that so much of this behavior is in our unconscious circuits. And so it's not, it shouldn't be seen as a weakness to try and reach out for professional help, or to reach out to a peer support specialist who has been through it themselves and can help mentor you and share their own story of hope and how they've done it, because that can be an absolute inspiration for someone to know someone else who's suffered like they have, and to see that they've gotten to the other end. Medication assisted treatment, I hate this term. It suggests that there's something else other than the medication that is critical to the treatment. And I would say medication treatment is really a foundation for which other things can be added because it saves lives. And, if the person's not alive, you really aren't going to be able to do much. So medication assistance, just replacing one addiction for another addiction. No, addictions like the 3 C's, craving, continued use despite harmful consequences. And medication treatment, what you should see is that the person's going into remission and they're making healthier choices and that they're having more of a sense of purpose or getting towards that. They're becoming more of having a sense of agency over the choices that they make. And they're not being just driven by thoughts about substance use day in and day out. So the hotspot map, it's much more red now, but I just think I always bring back this slide, even though people say, Michelle, it's so old. I just like looking at the 1999 slide because I think if it's possible that it looked like this in 99, it's possible that we can get back there. I really do believe that. So I really do have hope. But there's a lot of work to be done, and it's a lot of work that we have to do everywhere. But we're really focused on our HEAL community studies. So we've been highly affected, and that's what this map shows too, with all the red that you see in Kentucky throughout the entire state. So why do I have so much hope? Because I've seen cities like Baltimore, Maryland, where about 1 in 10 persons are using drugs intravenously. And it's been like this for a very, very long time. Baltimore City made treatment available upon demand. And so you can see that the circles here are heroin overdose deaths, and you see them go down, which is amazing. And they went down because the triangles went up, and the triangles are buprenorphine treatment. And you see them going up in starting really in like 2004. And that's because that's when the medication really started being implemented more in the community. It wasn't approved by the FDA until 2002. And, this is not a randomized controlled trial. This is like real world. And so this is just, I think, a beautiful testament to what medication treatment can do and what treatment upon demand can do too. In a challenging city. Baltimore is a challenging city. So good quality treatment really involves an assessment of the need for recovery support services. Not everyone's going to need the full court press of recovery services to do well or to improve their health and achieve abstinence. But a lot of people are going to need at least some of them, and there's going to be some who are going to need like all of them. So that's why it's important to have an individual assessment and to have our peer workforce available. And that's also why we need our care navigation, because the healthcare system in this country is incredibly complicated, and it is hard for any individual, especially when they're sick, to navigate it alone. And while treatment and recovery are not the same, we really want to see that they can and do coexist peacefully and beautifully, and we need more of it. And that that fulfilling one's potential are things that we should want for everyone with a chronic disease, not only those with a substance use disorder or mental illness. So that's one point that I say too is, I want recovery for everyone, not just, patients with substance use disorder. I want it for my patients who also have cancer. And I also want remission for my patients with substance use disorder. So we can go to our next slide. So I think this is where we really get to that chronic disease model. And I'm hoping that I've convinced you that, there's a lot of parallels with diabetes and cancer, especially if we remove the stigma of addiction. With diabetes and cancer, we see an essential role of medical treatment. With opiate use disorder, we have 3 FDA-approved medications. With diabetes and cancer, we also note that there's psychosocial behavioral treatments and modifications that can be helpful for people. And that's the same with addiction as well. And recovery support services, I think sometimes we just call those case management with diabetes and cancer, but a lot of it is about helping people get housing that don't have it, helping them navigate changes that they might have with their employment while they're undergoing treatment. There's just so many parallels. Sometimes we just use different terminology and different workforces. Monitoring the outcomes and adjusting the treatment to the individual. This happens with good addiction treatment. It happens with good diabetes and good cancer treatment too, where we're looking at the outcomes. And we're trying to, we're typically not looking at curing diabetes and cancer. We're looking at trying to control and manage and put into remission. We're trying to improve and preserve organ function and the patient's function and role in society. And, you know, those illnesses also use like a stepped care approach where there's a basic level and then you see what else that individual needs and you add things on. So, you know, not everyone needs or responds to intensive counseling. And that's really a parallel to, you know, exercise and diet, but we take a stepped care approach, and that is usually also a cost-effective method as well. Addiction treatment, we really are aiming in the Healing Community Study to get this to enter mainstream medical treatment and be available along the continuum of care. So if someone does go to jail or to prison, if they have diabetes and they're on insulin, they get to continue on their insulin. We need to be in the same place with methadone and buprenorphine. It can't be that, you know, they get their insulin, but then they don't get their methadone or buprenorphine when they go there. So we need to work on that. Wherever our patients go, the medicine needs to be able to go with them because it is so mortality reducing, or we're going to continue to lose really good people. So I see in the future, I think just a need and a continued need to fight back on stigma. Just to remind you of the definition, it's a set of negative and unfair beliefs that a society or group of people have about something. Stigma leads to discrimination. Recovery, you know, just important to remember that within the definition of recovery, recovery is built upon access to evidence-based clinical treatment. And we have treatments that decrease death. So making sure that affected individuals know about their clinical treatment options is absolutely imperative. And we want to have recovery support services available for all populations. We need to grow our workforce. Obviously, we need more doctors, advanced practice nurses, but we also need to have our workforce of peer supports and care navigators working hand in hand with the communities, because so many people are not yet linked to treatment and they struggle to be maintained in treatment. So we need to retain people in treatment too. So that way they can enter long-term remission and long-term recovery. So these are some recommended readings. The Facing Addiction in America, this is the Surgeon General's report. It's meant for a lay audience that had that figure of the brain changes that I showed you earlier. That's in there and explained in lay terms. There's also tip 63. This is meant for patients, families, policymakers, addiction professionals, and healthcare. So there's different sections that for different groups, and that's very helpful. That was just updated in 2021. There is a Legal Action Center report that's meant for eliminating barriers to treatment. This is, I think, very, very helpful. And there is an older Huffington Post project that's called Dying to Be Free. And there's some stories from Kentucky that are in there as well, if you haven't seen it. This is, I think John said, but we'll share these resources as well.
Hey,
Or if you want to
Lofwall, this is Mackenzie Clark with Bluegrass Care Navigators, and I had a question about the US map that you showed. I'm just curious your thoughts why it looks like the Midwest has much more blue today than the rest of the US. It looks like the kind of central and northern Midwest.
So I think it's all much more red now, because that's 2014. I think like the Appalachia is just, that whole area is very dense. I don't know why, honestly, Mackenzie, I'd have to think harder to answer why it looked like this in 2014, like why it looks like Wisconsin and Illinois maybe had less. Maybe some of the north, like looks like maybe Montana, maybe in part because it's less populated, but then it is adjusted for population. So maybe there was less prescription opioid prescribing there at baseline. Because we know like that it all kind of stemmed and progressed from the baseline prescription opioids. That would be one idea of something for us to look at or think about. What do you think?
Yeah, I mean, that's kind of what I was thinking of, was access to prescriptions, were people not being given the same amount as in the other areas of the country.
Yeah.
And then
those Midwesterners are tough people.
Yeah. I mean, I guess I think about the jobs too. And, Appalachia has been so affected by the coal mines, but there's also a ton of farming in the Midwest. You would think that maybe they've had similar injuries that they were treated for. But yeah, I don't know. I think
maybe the marketing was different too in some areas. Maybe some areas had more aggressive marketing. Like the marketing in Appalachia and in like the regions of Eastern Kentucky and Western Virginia and West Virginia is very aggressive.
Dr. Lofwall, Nick Kimberlin here. Right at the end, you said like how people get insulin in jail and they should get their MOUD in jail like the same way. It should be offered, side by side. And I wanted to kind of comment on that because I have a personal experience of being in jail with a man that had diabetes, and they refused his insulin for over a week too. And once I got out, I was in drug court, and they not only refused his insulin, I found out that, he ended up having to be rushed to the hospital. But that aside, I think maybe judges are kind of unaware of what goes on in jail, because my judge in drug court thought that, we were allowed to have any medication that we take to go in jail with. And she said she was unaware that, narcotics weren't allowed. And I was just going to ask, what do you think would be the best way to maybe reach that population, like judges and DOC workers, and maybe educate them a little bit on medications for opioid use disorder and substance use disorder in general?
So great question, and thank you for sharing your experience. There's another recent article that we can share with you, Nick, that you might really enjoy reading. And I know, Chris, you're gonna probably remember the name faster than I would. It's Sinkman. Sinkman's the first author, and it's also, I think, from maybe from the U.S. Attorney General's office, and it talks about the Americans for Disabilities Act and how there are a growing number of cases where the criminal justice system in different venues in different states is getting sued because they're violating the ADA. So the ADA protects people's access to their medications that they're prescribed for legitimate medical illnesses, and opiate use disorder and other substance use disorders are legitimate medical illnesses. And so I think our Chief Justice is aware of this. He has had a conference several years ago reminding all of the judges in Kentucky of the ADA. And there is a recent and a very, I think, positive move with Louisville Metro Jail, where they are now working with the Moore Center to really get better access to methadone and buprenorphine in that jail. And I think in part, Nick, it's because of like the advocacy and education and publications that that are happening. And frankly, the threat of lawsuits, sometimes when stigma, sometimes it's not really about a lack of education, sometimes it's just frank discrimination. And I think that's going to motivate change too. So I think just having the information, and maybe we can just share that article with everyone who's here, put it in the newsletter, because it just really outlines case law very clearly. And when you have, just remember too, like the Healing Community Study has the policy work group, and you can put in policy concerns as someone working with the Healing Community Study, where you have a question like, you saw this happen, what can we do? You know, then it comes to our policy work group, for which there's several faculty that really keep abreast of all the laws and regulations and can try to give feedback and do our best to push back on stigma and discrimination or regulations that aren't making sense, maybe old and not needing to be changed.